Hi, my name is Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK, and I'm also a consultant in private practice. Now, if you've been joining us for our Facebook Lives, you'll know that this is a real excuse to just talk about all things shoulders, some interesting things in the research, some shoulder sleuthing, so giving you some challenges in terms of some unusual causes of shoulder pain and things that you might want to consider in terms of your rehabilitation or your diagnosis. Sorry, I'm just going to turn my phone off, which has just started beeping in the background. But also just to talk about some rehab tips and tricks. Now, we had a diagnostic challenge last week. We had some technical issues. So I've come back to my house tonight, even though it's freezing cold. We've got no back walls. And we have got electricity, so that's an upside. So hopefully it's all going to be fine and the Wi-Fi is working, which is the most important thing. So far, so good. Great to see some of you joining us. Hi, and thanks for coming this evening. Now, what are we going to talk about tonight? Well, a couple of weeks ago in the chat, Marlene, who joined us for the Facebook Live, said that she wanted to know a little bit more about subscapularis rehabilitation. So I guess the first question is, do we ever need to think about subscap in isolation? If so, when? But also, who are the patients where subscap is more likely to be the issue? Because if we're honest and we look at the majority of research around shoulder pain, then actually it suggests that generally patients, certainly with non-traumatic shoulder pain, some of the key issues seem to relate to a loss of force production in external rotation. And certainly most of the evidence suggests dysfunction or weakness or loss of force production in that posterior cuff rather than the anterior cuff. Now, that's actually really interesting. If you look at subscap, it is the big daddy of the rotator cuff. It's really big. And in fact, if you look at subscap, it's bigger than the other three parts of the rotator cuff put together. So it's a really big, meaty muscle. And if you look at its attachment into the humeral head, about 60% of it is tendon, but about 40% is muscle right into that bone attachment. So it's a really big muscle. Very meaty, lots of mechanoreceptors, and definitely, like the rest of the cuff, has more than one function. So obviously it has a stability function in terms of being a buttress and balancing out those big prime mover muscles that are more superficial. Certainly if you look at activation through abduction, it works in balance with the posterior cuff to help counteract the force couples and the superior force generated by deltoid. So again, very important in that inferior glide of the humeral head. Similarly, in extension, again, if you look at Karen Ginn's lovely research, if we look at elevation through flexion, the posterior cuff works harder, whereas if we look at working into extension, then the anterior cuff works harder. So we immediately get an idea of the sorts of exercises that, if you like, would bias that stability function of subscap. But then, of course, like the posterior cuff, it's got its torque production role as well. So in terms of pure internal rotation. So we understand that from the literature. I realise there's limitations of EMG research, but it's kind of the best we've got in some ways. And I do think we can extrapolate some useful things for it. But again, you can imagine in terms of subscap being an internal rotator, there's a lot of other big muscles that do that too in terms of our lat dorsi, our teres major, and our pectoralis major. So when we come to rehab, we just need to remember that. Now, if we look at subscap and when it gets torn, it's certainly the least commonly torn when we compare it to supraspinatus and infraspinatus, though the research would suggest that it's probably undiagnosed. So does that suggest we cope better with it or not? Well, we'll come back to that in just a moment. But generally, when you look at the mechanism of injury where people will get a subscapularis tear, it's usually a hyperextension injury or a forced into external rotation. So it's probably no great surprise that when we look at some of our older populations who have a dislocation of their shoulder, then subscap tears can be associated with that. So clearly very important in that mechanism in giving us some early cues. Now, the other interesting thing, whether it be a traumatic tear or it be somebody with a degenerative tear, particularly it's in the upper part of subscapularis where it starts to interdigitate with supraspinatus and the rotator interval, is it can actually destabilize the long headed biceps. So when patients might come with a really unhappy biceps that might be clicking or subluxing in and out of the groove with external rotation and even more so in elevation positions, it's very important to unpick that history and consider subscap as a potential culprit, if you like, in contributing to that. Now, when we look at patients where maybe we have to think about subscap, because again, we could argue, do we really need to be specific about one individual muscle? Well, interestingly, the evidence would suggest there are some key groups where it can be really relevant. There's no doubt there are times when it seems to, if you like, have weakness when we do long-term follow-up, particularly after certain surgical interventions. So if you look at an open Bankart repair, if you look at Latarjet, probably because of the type incision and what's used to get access to the joint to do the repair, then it's not uncommon in longer-term follow-up studies to see subscap dysfunction, not only concentrically, but interestingly, eccentrically as well. And clearly that's really important to somebody who's going back to sport, who's got to be able to withstand load. If that subscap can't cope eccentrically as well as concentrically, then potentially that's a little bit of a chink in their armor. And as I say, there are studies that clearly show that there can be subscapularis dysfunction later down the line. Now, we also see evidence of fatigability or reduced fatigability, if you like, in subscap, again in association with patients after anterior stabilization. So again, we just want to be really vigilant about testing in those groups. Now, of course, I test it in every patient I see, but those are the patients that you might expect to see it as more of a feature. If we look at other groups, if you look at patients having arthroplasty, it's a time where, again, you want to really communicate with your surgeon, because again, there's absolutely no doubt that in patients who, again, they've if you like, compromise subscap to get access to the joint. Again, depends on the type excision that's used. But again, you need to know about tissue quality in subscap, but also importantly, any decisions the surgeon might make. Sometimes the joint can get a little bit overstuffed because of the type of prosthesis they use. If you've got a lady who's a little bit osteoporotic, who's not got very good tissue health, if you've got somebody who's smoked a lot, lots of negative lifestyle factors, all those things mean that that subscap repair after they've kind of used it to access the joint is more likely to fail. So again, very important. The other thing that's really interesting with your arthroplasty population is, again, there seems to be some evidence, and this is your total shoulder arthroplasties rather than your reverses, who don't seem to, it doesn't really matter if subscap's there or not. In your total shoulder arthroplasties, interesting, there's also some evidence that patients have got subscap dysfunction. They scan, they can't find any evidence of a tear. And so there's some suggestion that in trying to access the joint, they actually overstretch the subscapular nerve. So, and so again, that can be more of a neurogenic fatty infiltration and dysfunction. So again, always knowing what's happened during surgery is really important, so you can kind of preempt those things and reflect it in your rehab. Now, the other group that's interesting, if we look at specific sports, perhaps where patients might have, we might want to consider subscap. The lovely Sally McLean, who's somebody who's been a great part of the Steps to Success community, did some lovely research with Karen Jin where she looked at swimmers and actually showed that having weakness in extension was a predictive factor for patients with shoulder pain. They found that on average, if they kind of looked at normal strength measures, then if they were around 13.5% of body weight in terms of their extension strength, then they didn't seem so likely to get injury. Now, we all know when we look at risk for injury, there's multitude of factors, and training load is probably one of the biggest issues, along with our whole biopsychosocial model. But it's interesting that in that particular group, extensions seem to be the most significant finding. Certainly, when you look at swimmers, their ratios in terms of anterior and posterior cuff, when they're not painful, are the same on both sides, so you've got an easy comparison. But that extension, of course, there are prime mover muscles that extend that could be weak. But remember, we also said that subscap's really important. So again, a good case for isolated testing. Now, if you look at the literature in terms of what gives us best value in terms of testing, well, there's lots of tests out there. We had the lift-off test where basically you put the patient's hand on their back and get them to lift away, or you take it away and ask them to hold it there. If you get them to push you away, it's the lift-off test. Essentially, if you then take them into that position and ask them to hold them there and they can't, that's the internal rotation lag sign. We've also got the belly press where they put their hand on their tummy and push. We've got the Napoleon, which is another version of that, but essentially if patients are pushing, what you're looking for is they get nice pressure without any wrist inflection and no drop of that elbow back. Now, again, we also have the bear hug test, which is where you get the patients put their hand on their opposite shoulder. You need to make sure they're in about 45 degrees of shoulder elevation for this test to have its maximum reliability. Originally, there were two tests reported with the bear hug, one in the lower position and one with the arm elevated at 90, because we also know there are two parts of subscap, an upper and a lower. Some authors postulate that the upper is more about those about working through abduction in balance with the posterior cuff, whereas that inferior part is more about stability. But that really, we don't have a lot of evidence to support that. And I don't think we need to get really vigilant about which part's working when. We just need to reflect that it has a couple of roles and reflect that in our rehab if a patient has significant weakness. Now, the bear hug, as I say, is just putting the hand on the opposite shoulder and saying to the patient, don't let me pull you away. Now, if you look at tests for subscapularis, generally, they have high specificity and low sensitivity. So doing combinations can really help in terms of your decision making, but as ever, history is all. So I always test the cuff in prone. I sometimes look at it in supine if I'm looking at it eccentrically through range. And remember, if you lie somebody in prone and have the arm hanging down vertically, that's where your ratio is 1-to-1. So actually, if you don't have any other way of measuring, or you're not doing more formal strength measures, it's a really quick, easy way to pick up weakness if you're struggling in other positions. So again, those tests that are reported in the literature are useful, but I like to search it out a little bit more and see if I unload the arm, can I actually find somewhere where subscap can do its job? Now, Marlene's question was all about rehab. So I've already given you lots of clues there in terms of Karen Jin's lovely research and that of others. Now, there have been studies looking at what are the best value exercises in terms of subscapularis. Well, no great surprise, internal rotation. So they've looked at internal rotation in neutral, they've looked at internal rotation at 90 degrees, and also looked at things like an isometric belly press test. Now, when Karen Jin looked at those different positions, so she looked at the 0 degrees, the 90 degrees, but also looked at 90 degrees in supine, she actually found all of those different exercises activated subscap within 30 and 50% of maximum voluntary contraction, so moderate levels of activity. So again, I acknowledge that EMG is not without its flaws, but again, it's kind of the best that we've got. Now, what was really interesting with Karen's research is that that belly press actually was the one that relatively isolated subscapularis the most in terms of lats and pecs not contributing as much as in those other exercises. Again, supporting the weight of the arm relatively reduced the contribution of those muscles, but not as much as the belly press, which is really interesting. Now, the other thing that's important is looking at higher load in terms of exercises that give you best value or greater maximum voluntary contraction. If we kind of accept we might be able to use that, then a push-up plus is great, but has a lot of lax activity as well. So again, we just want to be clear that our patients maybe aren't adopting protective patterns, because that's maybe pecs and lats are the things that often, if our patients are a bit fearful of movement, a bit scared of moving, that's what they tend to protect with. So again, as long as we're giving good cues and the exercise is working for our patient, then they're very simple but very valid exercises. Now, another study, again looking at best value higher MVC exercise, also looked at a PNF type pattern in terms of pulling down from kind of shoulder height down across the body in a diagonal pattern. So basically just doing internal rotation, but through more of a diagonal pattern. And again, like the push-up plus, that gave some really nice higher levels in terms of that subscap activation. Now, again, for me, there's a couple of key things. So one of the other groups that I didn't mention in terms of when subscap is really important is our massive rotator cuff tears. Now, if you've joined us before in one of our Facebook Lives, we did a whole session looking at massive rotator cuff tears. And those of you that joined us, I'm sure will remember that we said when we're looking at those patients who do best with conservative management and actually some of our surgical options like arthroplasty, the bottom line is that essentially, if your subscap, one part of your subscap is intact, with a bit of teres minor, you are far more likely to do well with rehab. So it's a really useful predictive element. So where would we start with somebody like that? Because they're not going to be able to start with these high range movements. Well, remember I talked about those two functions. Subscap is active in extension. So one of the early entry exercises I used to like to use with my patients, thinking about that stability function, is just attach some TheraBand to a door. Sorry to mention TheraBand, but it's very useful, low level resistance, nice and proprioceptive and very easy to progress. And we can add load in as we need to. So one of my patients with a massive cuff tear, or maybe even somebody that I'm starting rehab after a subscap repair and starting some gentle loading, if I get the patient to pull back into extension as they internally rotate, and actually I quite often get them to do a step forward as they pull back. Again, we have some evidence to suggest if we integrate the kinetic chain, it just helps facilitate that local recruitment. It's a little bit more proprioceptive, and it probably has a distractive element to stop patients fixing or trying to compensate. But for me, that's a really nice exercise that targets subscap rather than abduction, which would be the whole cuff. So if I've got weakness and I want best value, then that extension with internal through range is a really nice exercise. There's nothing to stop me doing low level internal rotation. But again, what I really like to do is get the patient with their arm supported, because again, I want to take away lats and pecs as much as I can, get best value for subscap, let it catch up a bit, and then start doing more functional movements. So that's just a fancy way of saying, let's unload internal rotation, find where the patient can cope with a little bit of resistance or a little bit of weight, and then build it up until they can do it without support of the arm. And there's no doubt the nearer we can get them to 90 degrees, the more we target that torque or mobilizer function. But remember those other things we talked about, the push-up plus. We could easily start that in a less loaded position by doing it against the wall. And again, just really emphasize that protraction at the end, which seems to make it more specific to subscap. So some very simple ways that we can use the evidence. So you can see the exercises themselves aren't complicated. The key is working out whether you actually need to target in the first place. And again, I've highlighted some of those groups. Now, one group I haven't talked about, which again takes me into the other type of exercise that I do like to use with subscap, and particularly after my patients who've had stabilization surgery, but also my patients who've got stiff shoulders, is eccentric subscap work. So again, I can get the patient lying down on the floor. They can do this sitting next to a table, whichever's easiest, with the band behind them. Again, what I want to do is get them to shuffle down, which is probably why I do it on the floor, and it's easy to support, until they're at a point where they can just about pull that band down into internal rotation, and then they really slowly control that eccentric phase. Now, for my stiff shoulders, I want to do it as slow as possible, and there is some evidence that if I do that in conjunction with the metronome, maybe because it distracts them, maybe because it's an auditory cue, it just makes it easier for them to relax into that movement. I like using the TheraBand because it gives patients something to work against. And again, it's kind of a sensory cue, and that's their target rather than thinking too much about their shoulder. If you're going to use that in a stiff shoulder, respect pain. If it's really sore, they won't relax, they won't get the benefits, but also make sure the elbow's slightly in front of the shoulder so you don't get a real neural wind up. Now, when I'm using this in my instability population, I'll vary the speed. There's some really nice work looking at eccentrics and how they can just impact. There seems to be more proprioceptive value, and again, impact different cortical effects depending on the speed that we do them at. So again, a really simple thing that targets what the evidence suggests can be a problem in patients after those stabilization procedures. And of course, then the other thing that you can do is really good is plyometrics. So whether that be throws against the wall with your catch, so you're getting that eccentric and concentric activation, but under load and under speed. And again, we can just increase the load by using something heavier or doing drop and catch kind stuff. But again, targeting subscap rather than our posterior cuff. So some really simple exercises, very much based in the best that we have at the evidence of the moment. But really, what I'm hoping is I've answered Marlene's question, which was about how do we target subscap. I think the first question is, do we need to? It's a really interesting muscle because often you'll find that targeting the rest of the cuff, actually it sorts itself out. But what I hope I've done is highlight some key groups where actually it might be something you really want to consider. In your surgical groups, know what your surgeon's done in terms of their surgical approach, because again, that will give you a clue that it might be an issue. give it time to heal, but then think about doing some specific work just to make sure your patient hasn't got those deficits. As I say, anybody who's had traumatic dislocations, and particularly if they've had surgery, there is good evidence those deficits exist. But remember that interesting work by Sally. And importantly, when you look at your subscap rehab, don't just think about rotation, think about extension, and then ultimately about abduction working in balance with the rest of the rotator cuff. Now, guys, I really hope that's answered Marlene's question. That was a whistle-stop tour of the groups I think it's important for, and some simple things about the exercises that seem to give us best value. I'm just going to have a little look. So lots of highs, which is lovely. Marlene, you need to tell me. Yes, brilliant. Okay, that's great. I've answered your question, so that's super. Let's have I'm going to have to put my glasses on. I've got them tonight. I'm recently using these exercises for subscap tear post-operation, and it's amazing. Brilliant. That's fantastic to hear. And would you consider targeting it post long-headed biceps rupture? Oh, Julie, that's a great question. So I think with everything, long-headed biceps is a real funny one, because generally, if you've got an older degenerative population and it ruptures, it's kind of confirming that you've got an underlying rotator cuff tear. And so I guess for me, what I would do is I would look at the different aspects of that system and see which is weaker. So was it anterior or posterior? And that would help me target. But if I'm honest, if you've got an older cohort with a long-headed biceps rupture, it makes absolute sense to target subscap as well as whatever remnants of the posterior cuff you have, because those are the things that seem to correlate with good outcomes. So yeah, absolutely yes. And the other thing is, because obviously subscap creates one of the pulleys for your long-headed biceps, targeting that again in that population would make sense. So yeah, great question. And one group I hadn't mentioned, and definitely one that I would think about. But as I say, the age in that cohort is really important, because generally they tend to be an older cohort, and it does correlate with that underlying cuff pathology. Are there any videos on how to do these exercises? That's a really good question. I will see if I can post some links on the Facebook page. You might have to wait a few days because I've got a few deadlines at the moment, but I'll wait and I'll see whether or not that I can. Yeah, that's a really good question. Maybe listen back to the descriptions. And there's quite a lot of stuff on YouTube on the Liverpool shoulder. But I'm just trying to think if there's any subscat. Leave that one with me and I'll have a think. No questions tonight. Annette, a patient with chronic inflammatory subscap tear. Any thoughts? So when we're saying they've got a chronic inflammatory subscap tendon, I'd want to be knowing whether there was any underlying signs of any rheumatological pathology. Again, subscap's quite unusual in isolation, so I'd be looking at whether the rest of the rotator cuff is doing in job and whether it is truly subscap or whether actually it's the long-headed biceps, because long-headed biceps is generally unhappy because other bits of the cuff need to work a little bit harder. So I would be just trying to get the rest of the cuff doing its job and unload it, and then see whether that had an effect. But again, with a little bit of information like that, we could probably talk about that for 20 minutes, because I'd need to know a lot more about the case background to be able to actually work that out. Marlene, what would be the best way to get the latest on shoulder surgery specifics? So the best website probably is Shoulder Doc. If you go onto Shoulder Doc, it's got loads of information done by a surgeon, updated with all the latest evidence, and talks about the different approaches and talks about the different procedures. But again, I'll post a couple of links on the Facebook page, because again, there's some really nice stuff, particularly about that stabilization population, that talks about the different approaches and how that might influence your rehab and make you more likely of getting getting subscap dysfunction. Again, Tim's making other suggestions about the patient with the ongoing subscap. From my point of view, I just need to know more history before I start throwing out diagnosis. I'm really sorry. Carl, I currently have shoulder pain that's intermittent. The pain eases when I've stretched pec subscap. Any ideas what's going on? So again, Carl, it'd be really wrong for me to make any diagnosis or give any kind of key hints and things without meeting you and assessing you, because part of my diagnosis and knowing what's wrong, all those things are really important. What I would say is, generally, if we look at the evidence about doing any stretching, it doesn't have any long-term carryover, because things are often stiff because other things aren't doing their job. So if stretching at the front helps, you want to be working the back to try and get that working a little bit harder. Now, the caveat to that is, I don't know your history. I don't know if you've had trauma. This is not probably the forum to have that discussion, much as it's lovely to have you here. So please don't think I'm shortchanging you. I just wouldn't be doing my job without making sure I have all the facts. But again, if I had to do a webinar, in fact, we talked about pec minor all last week about the evidence for it, and generally, whether it's short or not doesn't seem to make a long difference. If it feels tight, you stiff it, it feels a little bit better. Do something to stop it being stiff. I hope that makes sense. So targeting the back of the joint would be my gut instinct, but get assessed and know what you're dealing with so that you then have the best advice. I hope that helps. Marlene, yes, I know him. Thanks, I'll do that. Oh, perfect. That's great. You know, Len, sorry, I've now understood what you were writing there. Shoulder Doc's a fantastic website for everything shoulder related. And it gives you some nice outlines in terms of shoulder rehab. We're just updating our, and there's a free ebook on there about loads of exercises as well. Carl, you're really welcome. I hope that helps. And I'm just sorry I couldn't kind of go into any more because it would be wrong of me to do so. So guys, here we are at the end of another Monday Facebook Live. More great questions, got me thinking. I hope that's been really useful. Again, I'll post some useful links. I'll have a think in terms of the exercises. I might be able to put some pictures on, but you'll have to bear with me for a few days, as I say. But otherwise, I hope as ever, we've given some useful clinical information, both in terms of what Subscap does, how that should inform your exercises, but also importantly, those groups that it might have more relevance in your rehabilitation. So guys, thanks as ever for joining. It's always a real privilege to have so many of you here. I feel very lucky that you give up your Mondays to listen to me geeking about shoulders for 25 minutes, half an hour. But I'll really look forward and see everybody. I'll really look forward to seeing you next Monday for some more shoulder nuggets. See you then.